Good morning, and thank you for being here. We're very, very glad that you could join us today. Now, before we get started, I just want to put a little ad in for Idea Fest, specifically March the 4th, 4:30 on at the University Club. The Center on Aging is presenting an Idea Fest event, Aging Deconstructed. The Art and Science of Living Well. We'll have 9 research groups, and it'll be Café Scientifique style, and you could ask questions, learn about the research that they're doing. And at 7 p.m., the signature event for Idea Fest, Tapping Population Data, a New Era in Health Research and Care, and that's at the Harry Hickman Building. And that will feature Dr. Scott Hofer, Dr. Ken Moselle, Dr. Michael Hayes, and Dr. Nina Chappell. Thank you. Thank you, thank you. You know, when you get up here, things change. All right, so it is my distinct honor to introduce our speaker this morning. Dr. Scott Hofer is the director of the Center on Aging, Professor and Harold Mohr, MD, and Wilhelm Mohr, MD, Research Chair in Adult Development and Aging in the Department of Psychology. He is currently the past president of the Society of Multivariate Experimental Psychology and president of the American Psychological Association, Divisions 5 and 20, Qualitative and Quantitative Methods. He is a fellow of the Canadian Academy of Health Sciences, Gerontological Society of America, and the Royal Statistical Society. Scott is an expert in longitudinal research. He is project director with co-project directors Andrea Pichinen, Jeffrey Kay, and Diana Koo of the International Integrative Analysis of Longitudinal Studies of Aging, also known as IALSA Research Network, comprised of nearly 100 longitudinal studies on aging in association with the UK Halcyon Network. The IALSA network provides a foundation for developing methods and accumulating replicable scientific knowledge from international longitudinal studies focused on aging and health-related change in cognition, health, and well-being. This research focuses on aging-related changes in cognitive and physical capabilities, the identification of lifespan factors, and health-related causes underlying change in functioning, and evaluation of differences across birth cohorts and countries. His research makes use of intensive measurement designs to understand within-person dynamics between psychological and physiological processes across different temporal scales and for the sensitive detection of individual change points in cognitive functioning. Please join me in welcoming Dr. Hofer to the podium.
Good morning, everyone. I'm delighted to be here. Thank you so much for that wonderful introduction. This talk is really fits within our series for both patient-reported outcomes as well as the research methods. And what I want to talk about today is this confluence of various research projects and programs that we have here at UVic, across departments, across colleagues, with Island Health, with Cerner Corporation, that come together in important ways to what we call this initiative, PROSPER, Participant-Reported Outcomes in Support of Participant Engagement and Research. And here I've replaced participant for patient. Patient is really just placed within the healthcare context, and we want to expand that out to be a full community or population context. So that's the reason for that here. I want to start with a thank you to many wonderful colleagues, many of my colleagues in our lab, Jeffrey Kay at Oregon Health Science University, colleagues at Penn State University, at the MRC Unit for Lifelong Health and Aging, in departments of engineering and the Island Medical Program, a number of colleagues with Island Health, and with Cerner Corporation, a more recent collaboration through Island Health here over the last few years. So I'll be talking about a variety of research that's come from many of these collaborations, from many of these colleagues, and probably others that I missed. Today I want to go through a range of research activities, and again, this is going to be a bit of a journey, but it's a bit of a journey that's going to link many of these ideas up. I'll talk a little bit about the IALSA network, a focus on these long-term, often widely spaced longitudinal studies of aging and dementia. I'll talk about more of our recent work. Actually, it goes back several years with colleagues Martin Slowinski on intensive measurement designs, that is measuring people much more frequently, often multiple times within a day or across days for a 2-week period, to learn much more about the within-person dynamics and to get better measures of individual change. Since we've moved here to Victoria 5 years ago, we've been in conversations and collaborations and proposal writing and active research with colleagues at Island Health and with Cerner Corporation, who are building out the electronic health record system there. We've investigated and implemented patient-reported outcomes in a clinical practice. We're working now on developing analytics and to detect signal in the electronic health records and service utilization and transitions and mental health. And what we're really aiming to do is to link new longitudinal data to the health records themselves, to really learn much more about what might be predictive or early diagnostic of service utilization and healthcare usage, and really to optimize healthcare. And then finally, we've been working with CanAssist, an entity here at UVic that's focused on assistive technology, and they have a program of research now called Can Stay Home that Cindy DeFrias is leading in terms of the evaluation component, and that's really to maintain independence at home. And so you'll see at the end of this talk that all of these things are kind of coming together in important ways and in new ways, I think, to optimize what we can learn about changes with age and health, but also to how we might intervene and provide information back to the participant or the caregiver or the provider in ways that will make a difference, that will optimize and healthcare and produce better outcomes. So that's the idea for today. Patient-reported outcomes is a big deal, and I'm going to cover, where some of that research and where some of those measurement developments are. The idea that we've been bringing to it for some time, and other colleagues in stress research or in daily diary research have known this for a long time, is that we need to measure people much more often than we typically do in longitudinal studies. So the idea here is we want to embed these intensive measurement designs, these bursts of frequent measurements, within longer-term, maybe semi-continuous longitudinal studies. The emphasis here is on within-person process. We're able to understand how a person changes from where they've been or from their pattern of previous change. It enables the measurement of dynamic phenotypes. One such phenotype is called stress reactivity. It's your own individual response to a stressor. And that's becoming something that NIH is beginning to fund and look at more carefully. And the idea, too, is how we might make these kinds of studies more regular, more efficient, and in a way, something that everyone does. And so there's a great deal of technology development for plotting your own trajectories and mapping your running and your activity levels. The big idea here, and that's this, the end of PROSPER, the participant engagement in research, is what value is this research to people, to our participants, to the clinicians and caregivers. So what can we learn from these that we might give back, that might actually influence their health and their cognition and their outcomes, the things that we're most interested in studying? How do we give back what we're learning about that in real time? And so it's this kind of feedback idea that people engage in our research, but they also gain from our research in a constant cycle. And so that's this idea of embedding measurements within studies that actually then give feedback to participants and begin to show how those can affect outcomes. So that's the idea. It's all about integrating practice with science, with benefits across the board, as I just mentioned. Basic science, we're interested in patterns of functioning, normative health, functioning, well-being, and why people differ from one another in these kinds of changes and in these kinds of outcomes, and why. What are the determinants? What are the predictors of that? We have a workshop next week where we're looking at the dynamics of changes in a variety of physical functions and cognitive functions, how these things change together at different periods of life. Much of what we know says these change rather independently. but it depends on how you look at it and how you analyze it. So even at these very basic levels, there's lots of questions we're trying to still answer from many of these studies. For clinical practice, we think we can improve diagnostics, identify patterns of health behaviors and symptoms, signs that occur before perhaps a person becomes aware of these. Embedded in a healthcare system, these kinds of measurements will permit us to evaluate treatment outcomes. In fact, that's how this collaboration with Island Health started. One of the surgeons, Al Hayashi, approached me wanting to look at outcomes from surgery. And we didn't have any evidence of where the baseline level was. And we kind of thought through it, and we thought, well, what could we do if we actually had a more continuous kind of measurement on all individuals, where we really could determine where a change has occurred. It would change everything for evaluation of a variety of treatments and outcomes in that way. And in terms of public and patients, for individuals to understand the impact of their own lifestyles and their own health behaviors on their own changes, on their well-being and their health and their fatigue and pain on that day, the things that they do that matter, it helps to pick up those patterns, and it can inform individuals about what works best for them. And so we've seen all this already in terms of daily variability and what matters. So that's the idea, again, is really trying to integrate all these different aspects of the research enterprise. All of these individuals and groups are already part of it. It's just trying to build it together in ways that inform each other. Okay. So improving longitudinal measurement requires improving longitudinal designs. I think one of the key take-home points of this talk today is that design matters. We can improve measurement, but unless we fit it to a particular design and purpose, that measurement may or may not work. And we see this happen in patient-reported outcomes. So what are patient-reported outcomes? They are defined as patient reports about their own health. They're self-reports. It could also be about circumstances surrounding their health or health care. The problem is that patient-reported outcomes, any self-report, is susceptible to a variety of types of bias, of distortion, of error, of recall error. And we also, coupled with these kinds of types of bias and error associated with self-report, we also need to move these out of the laboratory into the clinic, into the home, into everyday life. And so that's where there is just a burst of energy and creativity in how to do that. Kaplan and Stone, this comes from an annual review article, a very good one, I'd recommend it. It reviews that new developments in measurement of patient-reported outcomes has really improved how we measure health and health behaviors. They point out that there's a variety of technologies available for momentary assessment or end-of-day diary, so a lot of mobile technology, home-based computer in clinic, a variety of ways that this is now happening, including telemonitoring, measuring blood pressure, pulse, blood oxygen, home monitoring systems. A whole variety of things are now happening that make these kinds of assessments very, very easy. They also note in this review that to date, use of web-based technology or telemonitoring technology has kind of produced some mixed findings. It hasn't been demonstrated to always work to decrease obesity or manage diabetes or decrease smoking behaviors. But we're not sure why. I think the message is that these are still very, very early days. How we apply technology, how we apply better measurement and new designs to health and health care. These are very, very early days, and we're still trying to figure a lot of this out. So as I mentioned, the term patient-reported outcome refers to a questionnaire, a survey that's used in a clinical setting. Responses are self-reported from the patient. Another word for this is patient-reported outcome measures, or PROMs, synonymous. So they're used to obtain patient experiences about how they feel or function rather than objective clinical outcomes. So this is quite a lot of what we mean in terms of health and health change. To assess symptoms, functional status, health status, quality of life, health-related quality of life, health limitations, and perceptions of health care are all subjective experiences. We have to ask an individual what they experience, what they mean by this. So some examples, a variety of symptoms related to particular diseases, chronic and acute diseases, related to type, severity, frequency, duration of symptoms related to those. And so we see a wide variety of scales related to particular types of chronic diseases, such as arthritis or other aspects. In terms of functioning, we have scales of health limitations, activities of daily living, a variety of well-being, quality of life scales, and perceptions about treatment. These are all in the medical literature used in various clinical settings. My colleague Ken Moselle at Island Health came up with the term patient-demonstrated outcomes. I've always just kind of tacked on neurocognitive assessment to what we mean by patient-reported outcomes. But these are really patient-demonstrated outcomes, and there's a long history of these kinds of measures in psychology and neuropsychology. But these would include measurements of neurocognitive functions, as well as a variety of physiological functions. And they can be done in home, in clinic, or mobile. And that's, again, where things are really heading. I just got an email 2 days ago. Cantab is it's from the Cambridge Brain Sciences, a company in Cambridge. This is one of the longest standing computerized cognitive assessment devices for dementia and other purposes. They've just come up with an iPad app where it's touchscreen, and it can be used in clinic. This other screen shows another recent development, this time out of Baycrest, University of Toronto, and this is Cognicity. And it's a pretty nice web-based cognitive assessment battery that you can do, and that will give you feedback about your percentile rank in a population that shares your characteristics. So these things are happening. There's quite a few of them out there now. It's a lot easier and easier to track your level of cognition and your change. Now, there's also a number of developments that have been, in this case, funded by NIH for a variety of purposes. Phoenix is a toolkit trying to standardize a variety of measurements, primarily for use in gene-environment interaction studies, where the effects are very, very small, and where pooling across many, many large biobanks or data sets is required. So here the idea of harmonizing, or actually in this case, standardizing measurement is very important for very large-scale studies. So this is a toolkit of measurements for that purpose. PROMISE is focused on patient-reported outcomes. It's a variety, again, a variety of questionnaires and surveys covering a broad range of domains, again, trying to standardize measurement for this type of self-report. The focus here has been item response theory. So they've really tried to develop measures that have good properties. And this just shows some domain frameworks for the adult scales, physical health, mental health, social health. And you can see that scales of physical function, pain intensity, fatigue, sleep disturbance for physical health, for mental health, depression and anxiety, and for social health, ability to participate in social roles and activities and social isolation, a variety of these scales that have shown important to understand impacts on health outcomes, sometimes much later health outcomes than when these might be observed. Now, one idea is that many of these scales need to be embedded within electronic health records. And so this brings us back to our collaboration with Island Health and with Cerner. Which of these measurements would really be important to include on a more regular basis associated with the health record? So you can actually identify changes in individuals and link this up to understanding how changes in health and healthcare are recorded. So here, this book just came out of the Institute of Medicine, National Academies, and where this one focuses on selecting particular measures for inclusion in an electronic health record. And I'm sure you can't read this. These slides will be available, but you know, it's a variety of standard measures again. It's really trying to standardize this so that research can be comparable and pooled across broad institutions and data sets. But in the psychological domains, we have health literacy, stress, negative mood and affect, and some traits of personality, conscientiousness, optimism, self-efficacy. Again, psychological constructs that have been related to health. But a variety of aspects here. So there's a lot of activity and a lot of discussion and a lot of consideration about this. And I think one thing that we bring to it, and many of my colleagues here have worked with intensive measurement designs and collected data along these lines, is that we realize that there's quite a lot of intra-individual variability, that it's important to measure people more than once. And I'm not seeing a lot of that emphasis in this literature and in the development of these measures. These are often designed for between-person differences, to detect when a person meets a certain threshold that they need to have an intervention, without much attention to whether they're undergoing some change. Perhaps they were at a fairly high level of functioning at one point, but now they're undergoing some change, but it's still far from a threshold that would be amenable to intervention from a between-person perspective. So that's the idea here, is we really need to bring this within-person perspective to these kinds of research activities. Okay. So embedding patient-reported outcomes within intensive measurement designs. I've already kind of gone through some of these ideas. Let me get into a little more detail about this. One of our emphases has been on detecting change or change points prior to diagnosis of dementia. And so from a number of these long-term longitudinal studies, we've identified that the preclinical period can last for at least 10 years. This is a major problem and an increasing problem, although there is some recent evidence that actually the incidence of dementia is decreasing, perhaps related to cardiovascular disease treatment and education and other aspects. But given the population boom, it's still going to increase in overall numbers. 1 in 8 people age 65 and older will have Alzheimer's disease. Nearly half of people age 85 and older have Alzheimer's disease. This just comes from one of the studies, the Gothenburg age 70 study, where we looked back from point of diagnosis and found that there were these change points where there was an acceleration in change, in decline, in vocabulary and speed and spatial ability up to 10 years prior to diagnosis. So this was really where it wasn't detectable, except when we looked at it retrospectively in this way. We also know from a variety of studies, and this from Jakob Stern and others, has been replicated a number of times, this idea of cognitive brain reserve. The fact that individuals with higher educational attainment, higher socioeconomic status, higher childhood cognitive ability, and more cognitively engagement, more kind of lifestyle cognitive engagement, is all related. These are all indicators of reserve. And what this does is it delays the point of cognitive decline. It actually increases the overall ability such that when there is decline, it takes you a lot longer to fall to meet some clinical threshold for diagnosis. And so what this shows is that here individuals with high reserve will actually maintain it for longer, but then show a steeper decline. And so when at the time of actual diagnosis of dementia, that individual will progress much more rapidly post-diagnosis. So these are, so these kinds of ideas, this need for early detection, this opportunity for early detection, and this idea that individuals with different levels of functioning will undergo some changes without actually being detected using between-person approaches is another reason why we need this within-person design. So different people have different normative levels of performance, and the question here is this individual changing more rapidly than they have in the past? And for that, we need some historical or baseline data on individuals to judge whether they're undergoing change. So we need more intensive repeated measurements, and we need to kind of build out the analytics to be able to do this. What we're finding is it requires much more data than we typically have in these existing longitudinal studies, these 1, 2, or 5 year intervals between assessments. There has been a number of calls for more screening and longitudinal assessment of cognition for reasons I've just given. Here from New England Journal of Medicine 2012, what is still missing is the identification of a non-invasive, inexpensive diagnostic tool that could be used in population-wide screening to identify persons with preclinical Alzheimer's disease. And so this is one of the projects we've been working through with Island Health and Cerner to try to develop this out and work out ways that this could actually be embedded in a more regular assessment protocol. There's a number of reasons for this, and there's a number of potential benefits for early detection. Even though there are no currently known cures or interventions for Alzheimer's, there are a number of disorders that can lead to cognitive impairment that, if identified, can be attended to. And there's other ethical and decision-making reasons why people might want to know that earlier. So we're beginning to look into these potential impacts of early detection, as well as look at ways that we could actually do this. Now, how do we do this in a big way? And a number of researchers have been doing this for a number of years. It's an area called e-epidemiology, being able to do very large population-based studies through the internet or through some remote kinds of assessment. I attended a meeting that John Gallagher held a couple of years ago in Cardiff, and it brought together some of the kind of groups and cutting-edge research that these groups were doing, and it certainly is feasible. And so we've seen, large-scale cohorts, 500,000 people, who've been assessed regularly by internet. And these things seem to be working well. So this is another area in the future that I think things could go, and it points to early successes in this area. What I wanted to do now, so I've kind of covered some reasons for intensive measurement design, some of the why we're pushing towards this. I want to just very quickly step through what we're doing with IALSA and show how that kind of plays out, because we also need the very long-term follow-up. So in lifespan development, or in the more health-related area, life course epidemiology, there have been a number of very long-term studies that have investigated the effects of early childhood, of midlife contexts and lifestyles on chronic disease risk and changes in physical and cognitive functioning. A number of hazards have been identified, including low socioeconomic status, poor parenting, stress, lack of stimulation during gestation in a number of studies in the UK, in childhood, adolescence, young adulthood, later life, and across generations. This is the stuff that we're doing in lifespan development. This is the stuff that's being done in life course epidemiology and life course sociology, looking at how these contexts and lifestyles and behaviors really matter for later outcomes, for later life functioning, and really trying to link these things together. So a focus on very long periods of the lifespan is where these studies and where this research is at. And I think an area that continues to be a focus, and an important one for our investigation of existing studies, is when risk factors are most modifiable. So if we're looking at frailty or chronic disease or cognitive decline after 65, 70 years of age, what is going to be most predictive of that? And we haven't looked in midlife or early life as much as we possibly can. The data do become sparse, but I think as we look more and more, we do see how these things matter and map on to many of these later life outcomes. In terms, I would just point you to this book by Diana Koo and colleagues that describe an integrated life course approach to development and aging, bringing in the physical and social environment, the biology, and a variety of measurements across the lifespan. Diana Koo directs the 1946 British Birth Cohort, the National Study of Health and Development, and it's one of the earliest and longest running studies of its kind. There's a number of others in the UK and a few in the US and elsewhere that really contribute our our knowledge of these early and midlife changes. I am trying to bring a lot into this talk, and so I just wanted to, again, just put another flag post up that context matters and history matters. I think one of the clearest examples of this is the Flynn Effect. I think there's good evidence of increases in what people have called IQ, it's performance on cognitive tests, over subsequent decades, over the last 70 or 80 years. So why is that? Are people really getting smarter? Right? But it matters. It matters for how we analyze our data and how we interpret our data. So it matters. There's been many potential causes, no hard evidence, but just likely evidence that, changes in schooling, increases in test sophistication, increases in cognitively demanding professions. There's been clear secular trends in nutrition and in height recorded over the same period. More stimulating leisure activities, decrease in family size, all plausible hypotheses, all somewhat supported by different studies. But basically, context matters. It matters for all of us. It matters for all of us across our own lifespans, but it matters when we look at people born in different birth years who are participants in the studies we attempt to understand. So I just wanted to raise that point as well, because that's a component to how we understand change over time. And it also matters to how we measure many of the kinds of things we're interested in. As technology shifts every 2 or 3 years, we're off of some particular device or assessment device, we need to do something different. How do we maintain that continuity? It's all part of the same kind of problem we have here. Okay. So I've talked a bit about long-term longitudinal studies. I want to move on to some evidence from the intensive measurement designs and end up with how we might integrate this into a healthcare system. And so have knowledge discovery as well as potential optimizing the healthcare and feedback to patients. So I probably told you about the integrative analysis of longitudinal studies of aging already in some of my introductions. It's comprised of now nearly 100 studies, actually 99 studies on aging, health, and dementia, spanning 8 countries, variety of differences in these studies. We're interested in a lot of different questions. As I mentioned, next week we're going to look at the dynamics between changes in physical and cognitive functioning, the early life characteristics, the within-person dynamics, how all these things play out over the lifespan. We do it within a replication framework. We want to be able to ask the same question and test these questions in different studies, in independent studies, to get some idea of the reproducibility. A lot of sources of variation in these studies. Measurement models, population sample, design factors. And we approach it in a variety of ways. We're very interested in cross-method differences, in cross-cohort differences, cross-country comparison, and long-term longitudinal changes. The focus of IALSA is on coordinated replication. So we're kind of in between, where science is as it's normally done, where a result is produced and published, it's perhaps picked up by another study, attempts for replication, possible publication, and so on. What coordinated replication does is it brings many studies together at once to test the same question using the same statistical model with some alternative models possibly, and then all published together, ending with a research synthesis paper or meta-analysis. So you get a real strong test of that question and its replicability across different studies. So what have we learned from these studies? And you'll see how this kind of ties in. So these are long-term longitudinal studies. What have we learned? We learned these from a variety of so I mentioned about longitudinal studies, but many of these same questions have been asked in some experimental or intervention studies, in birth cohort comparisons, and even in some daily diary studies. In terms of engagement in physical activity, mental engagement, and social networks or social activity, these have all been found to be linked to long-term cognitive abilities, to change in cognitive abilities. But what we also see are vast differences in rates and patterns of these changes. From many of these studies, we've identified a variety of risk factors. Increased risk are a variety of health conditions, particularly cardiovascular disease and diabetes. Amanda Kelly is leading up a few paper projects on that. The ApoE4 has been replicated across many of these studies. Depressive symptoms, vision and hearing deficits, smoking are all related to some form of these health and cognitive outcomes. For decreased risk, as I mentioned, physical activity, cognitive engagement, social interaction, Mediterranean diet, educational attainment, socioeconomic status, higher childhood IQ, those markers of cognitive reserve are fairly stable predictors of maintaining cognitive function later and longer in the later years. These come from these kinds of long-term longitudinal studies. This all made sense to me as I was trying to link together this massive area of research, and here I feel like I'm just kind of slogging through it, but I think it's important to do so. So as we've moved from these longitudinal studies, we've learned about these modifiable risk factors, these physical and cognitive and social engagement, as well as these other health conditions. These are all now linked to a variety of stress responses, of chronic stressors, as well as daily stressors. So as we investigate the kind of long-term and modifiable effects on these changes in physical cognitive capabilities, we find that low SES and stress during gestation, early in life, these are the kinds of things that those very long-term longitudinal studies have found. We also find these in studies of, beginning at age 60 or 70. So in individuals who are experiencing more stressors at that period of life, it's also very much related to your cognitive and physical outcomes. So stress is the kind of common component here that a number of my colleagues are looking at. Stress is the sum of all wear and tear caused by any kind of vital reaction throughout the body at any one time. That is why it can act as a common denominator of all the biological changes which go on in the body. It's kind of a speedometer of life. This is some work that Tina Quaid is working on now, the role of stress and cognition in later life. So why is stress important? It's important because it is related to physical and cognitive outcomes and emotional outcomes. And it's also treatable. So in terms of physical health, metabolic disorder, cardiovascular disease, hypertension, stress itself is a risk factor for these chronic conditions. For emotional health, depression, anxiety, addiction. And for cognitive health, we find it related to a decrease in performance, MCI, dementia. The pathway is kind of through stress, at least partly through stress. Now, stress itself is very much a subjective kind of outcome. It's a self-reported outcome. There are some ways to get it objectively through cortisol or electrophysiological monitoring, but the correlations aren't that high. And still, I think many of the stress researchers are relying on self-report, getting us back to the patient-reported outcomes. So subjective stress is very much within person. It's when the demands exceed the personal and social resources the individual is able to mobilize. So it depends on the resources, it depends on the experiences, it depends on the person context. So most of the stress research that I'm following, and my colleagues David Almeida and Martin Slawinski, Rob Stosky, colleagues here, are focused on the need to measure these kinds of experiences, the stress experiences, repeatedly, more often than we would typically do in a long-term longitudinal study. And this is where this idea of a measurement burst comes in. The need to measure people much more frequently within a day or across days to really capture this intra-individual variation. Okay. So I mentioned the kind of long-term longitudinal studies spaced every 3 or 4 years. The IALSA network has affiliates of about 100 of these types of studies. Many of these are still active, have active data collection, and we're still learning quite a bit from these studies. Only a few of these studies, like the Oregon Brain Aging Study or the Rush Memory and Aging Project, measure people as often as every year, sometimes every 6 months. One instance every 6 months, but about every year. And these typically are focused on dementia outcomes, and changes that progress much more rapidly. So we've had this kind of view that changes with age, most of these studies are about aging. We've had this view that changes with age are often gradual, they're cumulative, that the kinds of patterns of change are just going to be smooth and gradual. And that's typically what we find. But why do we find that? Audience participation would be wonderful. Why do we find that?
Because it's what you're looking for.
Because that's all we're going to see, right? All we're going to be able to model, typically, are these gradual changes over very long periods of time, right? It's pretty tough to get at these more abrupt changes at this inter-individual variation. That's one limitation of these widely spaced studies. A lot of value to them, but that's one limitation of them. This measurement burst design, I think, is one key way to begin to get at those within-person dynamics in a very efficient way, where you're not having to measure people over long terms repeatedly every day. You'd wear everybody out. Except think about Jeffrey Kay's discussion and his home-based assessment, the use of pervasive computing or unobtrusive monitoring. That's a way in. And that's a very important way in, and something, again, we and other colleagues are pursuing here as well with Jeff. So the idea here is that we've got a lot of within-person variation, and that really, if we just measure people every few years, we're going to get a gradual kind of slope. And actually, when I drew this figure, I had in mind that we're going to get a kind of gradual kind of slope.
Explain the second design from the bottom on the previous slide. I couldn't understand the schematics.
This is the idea of an underlying factor. So here we would have multiple measurements of a common construct, and we would actually be modeling change at the factor level. So we are able to do this in some of the long-term studies, and I think, again, I might point to the Rush studies, where they have often combined multiple indicators of reasoning or of memory, and where they look at then change in these higher level constructs, a factor model. And this would just be a measurement burst design with multiple indicators permitting factor level analysis. And again, something I hope Jonathan mentions when he speaks later this term, some explorations of just how and whether these kinds of models really do improve measurements and our analysis of change over time. But it's something our lab is very much interested in, is how do we improve these measurements, and how do we improve design to get at these better measurements. It's all about efficiencies, and it's all about some trade-offs. And it's just how best to decide on which to go for. Okay, so coming back to Kaplan and Stone, that there's a variety of technologies available, and we know how to design studies now to do this kind of thing. Art Stone and colleagues did a number of studies of this, and just to determine how often do we really need to measure. In this particular paper, they found that end-of-day reports were quite reliable. You didn't get much of a different answer if you just measured people numerous times within a day or just at the end of day. So it's an important demonstration paper. And this paper, they evaluated whether the variability itself was an important indicator. And here they do recommend that it's the pattern of variation across days, here in pain or fatigue, that might be helpful for diagnosis, might be helpful for treatment. So again, it's that link of many of these measures back into the medical practice in ways that would be meaningful for diagnosis and treatment. Okay, so we've kind of stepped through why we're doing these long-term longitudinal studies and the need for these long-term longitudinal studies, but the fact that we actually need to measure people more often than we typically do in these long-term longitudinal studies, the opportunity for a measurement burst design to fill that gap, to provide that opportunity to embed these more frequent designs to get at these within-person dynamics that might be much more descriptive and much more predictive of later outcomes. So we've kind of worked our way through that. Now, how do we select our measurements? How do we look at patient-reported outcomes, which in many ways are some of the same measures that have been used in these longitudinal studies? They've just been adapted or modified in some way. But there's often a common measurement base. So patient-reported outcomes do fit into our stressor research and our well-being research and many of our kinds of health surveys and questionnaires, health behaviors. We're talking about the same thing. A patient-reported outcome is really just in a clinical healthcare environment. But the point here is that really we still know very little about how often we need to measure to get a good handle on the outcomes we're interested in, and what kinds of design we need to use to better capture that. So here the main point is that really few research studies have investigated the utility and impact of repeated patient-reported outcome administration. I've shown you just a couple. There aren't that many more. As a means for enabling the individual to establish their own baseline or reference standards. So we want to know, what's normal, what's typical. And as a means to identify change from what is normal or typical with a high degree of sensitivity. That's our idea of change point. We want to get change points at the individual level on a variety of measurable outcomes. We want to know when something's different, when we might be able to make a decision and make it and intervene in some way, or at least detect it and understand it. And that's what we're really about with these long-term longitudinal studies. What is causing change? What early life, midlife, current characteristics and behaviors and determinants cause change so that we can make a difference, so we can apply it. That's what I think it's all about here. I'm going to rush through a few things with Jonathan Rush's study. UVic well-being study. So I just want to rush through a couple of these studies just to kind of highlight some of the main points that it's important to measure people more often, that there's a lot of variability, and there's a lot of opportunity for capturing these dynamic phenotypes. So this was a 2-week study, a daily study, end-of-day assessments on a variety of well-being measures. It was a measurement study. How do these things go together? Is there a common well-being construct, et cetera? A variety of scales were modified for within-person assessment, for daily assessment. And so this is a life satisfaction scale, typically included in these long-term longitudinal studies, given once every 4 years. Here it was done every day. So in the last 24 hours, you can see how the questions were modified. And this shows a variety of individuals and their daily score shown by the kind of jagged line, and the red line on each is their general life satisfaction, just that standard scale as it's normally given. And you can see that there's a lot of daily variation, for some people more than others. And you can also see for some people that the average of those daily scores doesn't map on to the general life satisfaction score. So you get a different answer. And from a between-person differences perspective, you would get a different rank ordering of individuals and a different prediction or a different outcome. This just shows a variety of plots and the interclass correlations for a variety of the well-being scales, again showing that about half the variance is within person. It's how a person varies from themselves day to day. Quite a lot of it here, about half of it. It's a paper by Jonathan that looked at positive and negative affect and just showed that while the factor structure may be the same at both the between and within person level, the correlations between positive and negative affect were present only at the within person level. That it was on days where you had higher positive affect, you also had lower negative affect, something we typically don't see at the between person level. These are considered to be orthogonal to one another. This is a Cognition Health and Aging project. Marty Slowinski was the PI at an assisted care facility in Syracuse. Here we evaluated people for 6 days, every 6 months, so it's a repeated measurement burst design. We measured a variety of things, including a number of cognitive tests. This is just one of the cognitive tests, and what you typically see when you give a cognitive test is that people improve the second time, and then maybe a little bit more the third, but much less, you know, and it goes on. So that's what you see here. This is a reaction time test, a 3-digit string comparison, 3 digits, 3 digits. Are they the same or different? Respond as quickly as you can. And you can see here that people improve, especially improve the most between the first time they ever saw the test and the second time, and then the improvement begins to slow down. This is that 6-month interval where you see some forgetting. You see some going back to a previous level, and then again, a rather large step between the first and second session of this second burst. So again, you see this kind of learning pattern each time. But you can see that people begin to level out. And so what we can do is we can fit a model and estimate the asymptote, the maximal performance for each individual. And the idea here is that we can then model change in terms of their maximal performance over time. And we showed that this was a very sensitive design to model change in asymptote, that we could identify change reliably as little as 1.5 years or 2 years over the course of this study. This was in only about 100 people. It was also a very efficient way to separate out retest effects from change effects, which is somewhat of a problem in long-term longitudinal studies. And I don't have time to go into this. This is just a paper by Liz Munoz and Marty at Penn State, where the basic finding here was that global perceived stress at baseline was predictive of greater change in asymptote over the 2-year period. So here we found that stress indeed was related to change in cognitive functioning over a very short-term study. And just about to wrap it up here, I think. I hope. Actually, so I just wanted to quickly highlight some work that we did with Eric Shafansky. And again, members of our lab, particularly Amanda Kelly, led this up with us. And this is where we were able to embed a patient portal. Actually, there was already a patient portal, but it was extended to include repeat survey information over a period of time in a group of patients of a geriatrician on the island here. So we did a 7-day measurement burst design. And for this design, we looked at the SF36, the RAND short form 36, a kind of broad, multidimensional health questionnaire, and we modified it for daily assessment, as well as including a number of other measures, sleep, physical activity, well-being, stress. Again, the interclass correlations showed that for a number of these scales, that there was quite a lot of within-person variation across days. And what that means is that if you gave this scale on any particular day, you're going to get a slightly different response depending on the experiences that that person's had that day. So particularly for a scale like health limitations, the within-person variation was quite high, about 60%, whereas a scale for pain was quite low in terms of within-person variation. So depending on the condition or the individuals in the study, you know, you're going to get different sources of variance here. This is just really indicative of the particular sample you have. But we first looked at this just to show that there was indeed variation at both the between and within-person level. And you can see that the individual trajectories are quite variable day to day. This is on a variety of those subscales of energy, vitality, pain, general health. And what we found was that there were both within-person and between-person effects. So here, This table, just quickly highlight it. In terms of positive affect and negative affect, we found that the variety of these SF36 subscales regarding health limitations, emotional limitations, energy, vitality, pain, were all related to some form of well-being, either positive or negative affect. At both the between person, so how people differ from one another on average, as well as within person, how a person varies from themselves day to day. And this just shows some other effects for on days that you experience more stressors, there's a change in well-being, more physical activity, there's an increase in well-being, and so on. Okay. It was a very positive response. People enjoyed being in the study. There were some items that it was boring. There was too much tedium, too much repetition. You're basically giving the same items to the same people every day for a period of time. And so you're spending maybe 10, 15 minutes a day on this kind of thing. That's a big problem for these kinds of designs. And so that's one of the key features we need to work through, is how to make this a bit more interesting, a bit more exciting, a bit more something that people are willing to do over the long term. Not every day, but in terms of these kinds of measurement bursts. So that's one of our big challenges. But one of the big messages from each of these studies, each of these intensive measurement designs, is that this daily variation is systematic, that it matters what you do on that day in terms of outcomes that I think would be important to each of you. So physical and cognitive activity, social engagement, health behaviors, we find in both long-term longitudinal studies as being associated with better cognitive and physical capabilities. And these are all protective factors for a variety of chronic diseases. And and that some of these newer designs, these intensive measurement designs, show that these same factors matter on a daily basis to optimize health and well-being. And so I find it absolutely thrilling to see that there's convergence of what we're seeing here in terms of these long-term longitudinal changes and what matters to maintaining cognitive ability, as well as what happens at the daily level. It's almost, you're taking a magnifying glass and you're looking at these different windows of change within people. And these are systematic. In college students, in community older adults, in Swedish octogenarian twins, we tend to find many of these same kinds of outcomes, these same kinds of important aspects. So there's been a great deal of interest. I mentioned that there's been some mixed findings from the Kaplan and Stone annual review. But there's a number of new studies out there now. This is a study that is done in Germany and the Netherlands, and this is the beginning of a study where they have intensive personal rehabilitation following some cardiac events, some surgery. But after about a month or two, that personalized attention goes away, and what they found is that people revert back to their old health behaviors. So this was an intervention to improve your diet by eating more fruits and vegetables and by maintaining physical activity. And so they're looking at kind of an e-health program to follow up and maintain that. So it's these kinds of things, I think, that can work here, that can bring all of these different aspects together. So what I call an inverse perfect storm, the opposite of a perfect storm. We've got a lot of things going well here. We've got some terrific researchers here at UVic and elsewhere that we're collaborating with, but in terms of Center on Aging and psychology, sociology, engineering, the medical program, amazing things happening here on campus. Amazing things happening with Island Health, with their new research and capacity initiative, and a number of clinician researchers very interested in doing research, improving care, testing out new ideas. And in collaboration with Cerner, a partner at Island Health, developing a new electronic health record, where the opportunity to develop software and be part of that development of a patient portal, perhaps, and of evaluating the health records and developing new analytics to better inform both providers and patients. Remarkable opportunities, benefits to all. In my own view, I've strung a lot of things together today, from patient-reported outcomes to long-term longitudinal studies to more intensive measurement studies, I see that all of these things need to come together. And I guess that's my bottom line message. I wanted to highlight some of these various research initiatives and paths. But the idea here is that we really need to think about long-term semi-continuous cohorts. We need to embed this within the healthcare system. That provides the evidence we need to understand how treatment, how health behaviors all matter, and I think it can be improved at a variety of levels if we had that data, if we had those opportunities. So the embeddedness within the healthcare system, to me, is the next generation longitudinal study. I see this as working. I see this as just so essential. The opportunity to link the health records is one aspect of that. But the opportunity to provide this data back to the participants, to the patients, and to the providers or the caregivers is, I think, even more critical. So, just to wrap it up, we'd like to hold a planning meeting on this topic to bring together a variety of people, researchers, clinicians, patients, to think about how we can really design such a study, identify the targets for this kind of research. So incorporation of patient-reported outcomes or patient demonstrated measures within clinical assessments and healthcare system is the goal, I think. I think there's lots of benefits here to improve patient health behaviors, outcomes, patient management, to optimize measurement, frequency of PRO assessment, optimal indices and analytics. These are the research questions we're asking now. So it would be researchers, clinicians, community partners coming together to advance plans and implementation, determine priority needs, how best to transfer research-derived knowledge into clinical practice, into clinical care, to look at design factors, this problem of boredom, this problem of burden, of asking people too much too often. How do we get past that? How do we do that? For me, partly we do that is by giving information back, make it worthwhile, make it useful to them as well. And the opportunities for healthcare professionals to influence patient health behaviors outside of the office, much like that follow-up to the cardiovascular intervention, to maintain people, help people maintain themselves on a better diet, on a better exercise regimen, these kinds of things. Thank you so much. Whew. Okay. Andre.
I wondered if you could speak a little bit on the role of single subject designs in this larger context of more attention on within-person change.
Yeah, I like that question a lot. I think what we're pushing towards is essentially a large set of single subject designs. And I still value very much the between-person differences. I don't think you can ever discard that. I think when we sample within a person, we only sample their own experiences, their own context. It's a sampling of the vast diversity of possible experiences and abilities and prior contexts and all of these things. So as important as I think it is that we have to anchor our study of change within an individual, I think there's also that diversity of individuals that we must bring to bear in understanding the full context of change. So I want both. I really want it all. I mean, it all has to come together here. But you have a follow-up.
Yes, I wondered if the current state of the art of methodology in single subject design can even begin to address the issues that you're raising, or we need some sort of advancement in methodology before we can start talking about.
Yeah, this is a good question. We've tackled it in some ways in trying to detect individual change points. This has been something I've been after, and my colleague Graciela Muniz and others have been looking at this. we are unable to estimate, in most of these studies, random change points, where each individual has their own change point. They can change at different times before some events or this kind of thing. Very challenging. I see it as a data limitation. So I'm asking now, just how much data, how frequent do we need to measure an individual before we can get a good identification of that change point? And especially, so it's one thing to estimate a change point for scientific purposes. It's another thing to flag it for clinical purposes. But at least it begins to focus that, okay, there's something different. Something's changing. And we can begin to perhaps use an adaptive design. Philippe Rast and I have written that up a little bit, in terms of that's the time where you really want to measure more often to really make sure what you've got is a change point. There's something different happening. But a number of other colleagues are looking at this, Peter Molinar and others, in terms of these really strong within-person approaches. And I would say, Jeffrey Kay, when he was here a few weeks ago and discussed his home-based assessment and the more pervasive computing, this is where we're getting just streams and streams of data on individuals. And the focus is on really detecting that signal, detecting those differences when a person is changing from themselves. So these kinds of things are definitely going on. The within-person design is alive and well. But I do think it's the analysis and the challenge of detection at that level where things are at. Doug.
At what age would you like to start collecting data? and presuming it's early, the test would have to evolve throughout the lifespan, wouldn't it?
Yeah, I have certainly seen the value of early childhood, actually infant studies, progressing on to later life studies. You have to have a great stake in the future to initiate and do these things. And I value those studies and the people who've performed and carry on those studies very much, mostly in the UK, that they've had this kind of view. But every decade they initiate a new one. And we learn a great deal about this. I think it's very important. I think we need to study midlife more. I think this is a time where still a lot of health behaviors and a lot of lifestyles, a lot of things happen and matter that carry on. I honestly don't know about critical periods as much as I should from these studies. It's often very hard to determine that and detect, okay, one thing we'd like to learn from these studies is which rely on natural variation, right? So we've got that kind of causal issue ongoing in our analysis of these observational studies. Is it a person characteristic that leads to this, or is it really the context that matters or the lifestyle that matters? We're trying to always disentangle that. But it's those kinds of questions that if I intervened between 40 and 50 years of age, would that have a greater impact on maintaining cognition at age 70 than an intervention of 50 to 60? I don't know if we've ever really had strong results of that type. The data are very sparse, I think, but we'd like to get at that.
How do you start implementing these tests without skewing the results? In other words, if somebody reaches middle age and you say, okay, it's time to start bursting your responses, is that not going to bring with it any risk of a modified answer?
Yeah, so this is a great question, because I think that's where we currently are. If we're going to now embed these ongoing measurements for both a longitudinal cohort, which we typically don't ever provide any data, right? So all our participants in these studies, they never see their data. It's a very rare circumstance where they would be given their test scores. These are used primarily for scientific purposes and never provided back. If we move to now a model where we're providing feedback about a person's performance and change in performance, that potentially modifies their performance. But that's really what we want. So you're right. We need to work out designs where we can still extract and test those hypotheses that now, as we embed feedback into something, is that influencing the outcomes? Is that influencing the path? That's a critical scientific question. Yeah.
I've got a question from someone in the ether. Two issues that this individual. One is what would be the economics of recording large measurement data sets and the cost benefits of affecting changes? So that's one question. And then the second one is, at what point are we going to get benefits by connecting the data to interventions, if you could foresee that?
Yeah. You know, I suppose longitudinal studies are very, very expensive. And we see that with the Canadian longitudinal study. We see that with every one of these other studies. These are expensive research outlays. They keep research teams, sometimes large teams, funded for years, just to keep that data flowing and to keep the analyses going to produce that scientific product. The kind of e-epidemiology revolution and the opportunity for providing feedback, providing some value to people, I think, and make these kinds of assessments, these large cohort assessments, I think, much less expensive. If it's done remotely, via the internet, via mobile devices, I think we can begin to offset many of the costs associated with that. The benefits of embedding it within a healthcare system are that you often have routine lab reports, a variety of other kinds of data being collected on individuals that, given their permission, given the appropriate consent, can be linked. And so, in a way, you have a built-in platform, a very efficient platform that's already running. A lot of data are already being collected. The problem is it's unstructured. So that's the big difference between data collected from a healthcare organization and data collected from a cohort study. It's whether you have a structured design, very regular assessments on everybody, the same things, versus an unstructured set where you have often some routine lab reports, but often only when there's a problem, right? So that's the real challenge, is linking these two. And thanks for the question, because that helps me bring together what I wanted to convey today, is that we need all these aspects. We need the integration with the healthcare. I think there's great benefits there. We need the kind of long-term longitudinal study that has regular assessments. That provides that anchoring, that validation, that constant opportunity to evaluate change over time. We need the more intensive measurements to get at these dynamics and understand just what's really going on within an individual. And I think all of this would provide a very flexible platform for this kind of ongoing study. For different people, for different purposes. I mean, it should be a very flexible kind of platform for this kind of research and this kind of opportunity. I think there's lots to learn. I guess I see this as really the way forward now. Yeah. Andre.
Is there practice to use assessment, and particularly cognitive assessment, not only to get information from the patients, but also as we spoke before this closed feedback loop, but also as to prevent or to treat certain conditions. For instance, if increased cognitive activity can offset or prevent or affect the development of Alzheimer's, then the doctors would be interested in, I don't know, having their patients play a chess game every week, and then we can record the time over performance of that cognitive test and use that as an assessment for prevention. Is such practice widespread? Are there precedent? Can you speak on that, please?
There is a lot of commercial interest in cognitive training, brain training programs. Yeah, there's quite a number out there these days. I don't think they'll hurt you. I think you're okay if you want to use them. I don't think there's a lot of evidence that they'll benefit yet. There's been very few studies, actually, and they've shown only very small effects and many null findings. But that's for, the kinds of, and that's even for some of the more intensive deposit science work that's, where you're doing an hour a day for some period of time. I think it's, yeah, so I guess I'm a bit agnostic on whether or not they work. I'm a bit more on the negative side of whether indeed they work, much more positive about the kinds of physical activity benefits. I think that's been shown across the board. Some very good clinical trials showing that, impacting a variety of outcomes, health outcomes, cognitive outcomes. But certainly maintaining a rigorous intellectual engagement is very important. But you get that socially, you get that in a variety of ways, and I think diversity here is an important aspect of that. So yeah, do the brain training, but don't do it only. Yeah.
I would hazard to guess that a lot of the brain training effects, you know, if they do find positive things, I would be interested in knowing what social component there is to that. So you have a number of individuals who are playing bridge, and they're doing really, really well. Well, is it that, you know, they're playing bridge and they're keeping up with all those different scores, or is it that they're in a social community and that is what's supporting them? So I think it would be hard to sort of separate, you know, where the variance lies with what effect, but I would have to say that I would guess that social component would be a really important factor there.
Yes.
I'm just wondering, when we talk about within-person change, do you think then maybe, for instance, something like lumosity might show us changes within the person? So maybe you're saying that you don't see improvement in performance, but maybe if somebody was to continue doing it for a number of years, they would see perhaps change within themselves, and that might be useful. Which is another thing, another benefit of being here. We have a very vibrant high-tech community. Yes. Maybe we could get somebody interested in producing some games that would allow people to do tasks like assessment tasks that aren't boring, that they would really not even perceive as being assessment tests.
Yeah, I agree. I think that's an important part. It's an important aspect to evaluate. Right? I mean, we need to do more evaluation studies of this type. As I mentioned, anytime you take a cognitive test or a cognitive game over and over again, you're going to get better until you don't, until you reach some asymptote. And there's been one study that followed people up for 100 days and found that they were still improving a little bit, even at the very end here. So yeah, I mean, we all improve. I think the big challenge here is to understand whether that improvement on one particular type of test transfers to other types of abilities, transfers, you know, to cognitive ability in general. And we find little to no evidence for that kind of thing. I think that's been the big disappointment here. And these studies go back to the 1970s or even earlier. Where, you know, we really were looking for these transfer training effects. The fact that you do something with your attentional processes or your speed, and we want to see it transfer to other aspects. Yeah, not a lot of success, but still a lot of hope, I think. Yeah. All right. Thank you all for being here. I appreciate having the opportunity to kind of throw out a lot of ideas and a minor vision on how we might all bring it together. I am hopeful, and I know a lot of us are hopeful that we can make something like this work here, and I think we can do it. So watch for that Prosper meeting in the next few months. All right. Good day.